Today. So, on behalf of Department of Medicine at the Macon and John Brock Virginia Health Sciences at Old Dominion University, I welcome and thank everyone for being with us this morning or this afternoon. We are pleased to host the Harry H. Mansbach Endowed Lectureship today. Since its beginning in 1996, the Mansbach Lecture has afforded us the opportunity to host some of the nation's best medical and scientific minds, and we are thrilled to have Dr. Vimal Mishra with us today to continue that tradition. Before I turn things over to Dr. Mishra, I want to recognize and sincerely thank a few cherished members of the Mansbach family. We are deeply grateful for Mr. Tom Mansbach, the son of Harry H. Mansbach, and a valued member of our EVMS Foundation Board of Trustees, Miss May Lynn Mansbach, daughter-in-law of Harry, and Miss Sally Herman, his daughter. Each of them has been a steadfast and generous supporters of both the institution and this lecture. Their ongoing commitment has not only honored Harry's legacy, but has also inspired and elevated the work we do. We remain truly thankful for their continued support. Harry H. Mansbach was a prominent businessman, lawyer, and a civic leader in Hampton Roads. A graduate of Yale College and Harvard Law School, he began his law career in Norfolk before volunteering to serve U.S. Navy in response to Pearl Harbor. He later returned to Norfolk to work at his family clothing store, eventually becoming president. At 55 years of age, after selling the business, he went back to practice law at Kaufman and Cannolis, where he remained as a practicing partner until 2000. A native of Norfolk, Mr. Mansbach believed in giving back to his community. An active member in the Jewish community, he served as the president of Ohev Shalom Temple from 1951 to 1955 and earned the B'nai B'rith Distinguished Service Award. In 1975, he was named as first citizen of Norfolk by the Cosmopolitan Club, elected trustee emeritus of Old Dominion University, and awarded an honorary doctorate of human letters by Eastern Virginia Medical School. For those of you not familiar with EVMS history, Harry is one of the reasons this school exists. He was an early and enthusiastic champion of the fundraising effort that made it possible for EVMS to welcome its first students in 1973. He chaired the board of visitors when we received our first accreditation, and he stayed involved with fundraising campaigns through the 1990s. In 1999, Harry H. Mansbach Chair in Medicine was named in his honor, held by a chair in the Department of Medicine. Harry passed away in 2002, but his family members carry on his legacy. They share their father's commitment to this wonderful institution, and for that, we sincerely thank them. And with that, I would now like to introduce our 2025 Harry H. Mansbach Endowed Lecture speaker, Dr. Vimal Mishra. Dr. Vimal Mishra is a healthcare executive, a physician leader, and innovator specializing in clinical transformation, digital health, AI, and healthcare system optimization. As Chief Medical Officer of Mercy San Juan Medical Center, he drives strategic initiatives to enhance patient care, safety, and operational efficiency. Previously, as Vice President of Digital Care and Associate Chief Medical Officer at University of California Davis Health System, he led enterprise-wide digital transformation, launching California's first urgent care at-home program and AI-driven operational improvements. Board certified in internal medicine and clinical informatics, he has influenced national policies through his work with American Medical Association and other advisory boards. A recognized thought leader, Dr. Mishra has contributed extensively to advancing healthcare through peer-reviewed publications, national and international presentations, and scholarly activities that shape digital health policy and care delivery. As a professor of medicine and as advisor to UC Berkeley SkyDeck, he mentors future healthcare leaders and startups. His leadership philosophy centers on AI, digital transformation, operational excellence, and strategic collaboration to advance patient-centered, technology-enabled healthcare. And I'm proud to say that he's a good friend of mine also. Uh, Dr. Mishra, please welcome Dr. Mishra.
Thank you. Can everybody hear me? Can everybody hear me? Perfect. Thank you. Thank you. Thank you for that kind introduction, Rehan. It has been such a pleasure working with him. I was at VCU, and Rehan was the chairman for the hospital medicine there. So thank you for inviting me here and talking. And so to begin with, I wanted to just see raise of hand of how many of you have spent more time in front of the EHR instead of in front of the patient, talking with the patient. All right, there you go. And I think for those, I would certainly feel like this would help to understand how do we frame the next era of technology. And before we move forward, here is a very provocative question for you all. So I don't know how many of you have looked at and heard a few days ago, or a few weeks ago, something like that. There was a conversation with Bill Gates. And Bill Gates said, we will not need doctors in next 10 years. How many of you agree? All right. So let's examine that. Let's examine that and talk about it. Sorry, I have to go back and forth because I'm using my laptop. So this is, I wanted to show you something, but Dr. Qayyum already introduced me, so I'm just going to go past here and just talk about specific thing here. So what I did, this is a free version of this DID, which is similar to technologies you might have seen in Mufasa, the recent animation series which has come, where they are basically taking your words and kind of creating emotional and delivering speeches. And I just wanted to kind of show this. This is a free version. It can do much better. So just a FYI there. To begin with, so just quick disclosures. I have created this company called as HealthSight and a product called as MedAdvisor. There is no conflict of interest here. I'm not going to be talking specifically about this. Objective today, quickly analyze core principles and methodologies of artificial intelligence, evaluate real-world use cases of AI in healthcare. So that would be the big topic we are going to be talking about. Before I move forward, I want to just kind of talk about what to expect from today's lecture. So today we are going to be talking about, and we need to go backwards to think forwards as to what is happening in digital transformation. We will talk about EHR era. It has not been very long. We started this digital transformation in healthcare. We'll talk about productivity paradox. And I think today, when we were just before this conversation, we were talking about this and it came up organically. So we all are thinking about this and we'll go a little bit deeper and understand what that is. And then we are going to go into AI, today's topic today. We'll talk about some of the AI timeline types. We will talk about some of the machine learning in a very high level fashion. I don't want to be talking in a specific terms. I don't want us to be engineers, but just to understand what is happening under the hood. And then we are going to go talk about generative AI and how it has changed. We will talk about, reimagining clinical work. And most of you said that you invested more time in front of the EHR than in front of the patient. So how that is going to work out. And then some of the decision diagnosis. What does the research tells us is where we are going with this. and then AI clinical operations, because I am an administrator, I'm a chief medical officer, so I have to think about how are we improving clinical operations. And to take away, I wanted to go to that point where I'm able to help you create your own AI assistant. And we are going to see some demonstration there. So that would be something to give away. We'll talk about the limitations, and then we are going to talk about the next phase, what my crystal ball says and I think about. All right, let's get started. So in 2000, many of you have probably heard or read this book, To Err is Human, by National Academy of Health. This was the first time we were talking about error in healthcare, and we were killing 98,000 people because of those errors. We were talking about those issues which were system-based issues, and this is when we started talking about the system-based issues, which is actually causing more harm than motor vehicle accident, than HIV and others. So this really opened a conversation around why and what system-based improvement is needed. And that led to the conversation around transforming healthcare and health information technologies. Many conversation happened, and the conversation was, we are in the chart-based era, let's digitalize everything, and everything is going to get fixed. That was the promise of our EHR. We thought that we will digitalize everything which is happening in paper, pen and paper, should improve healthcare, should improve interoperability and everything else. Here, that time, President George Bush said, by computerizing health records, we can avoid medical mistakes, reduce costs, and improve care, all at once by the EHR. Let's see what happened. We also had this really famous RAND study talking about EHR will save us $81 billion, 2005. Remember those days? And in 2009, Obama administration actually passed HITECH Act. We invested $27 billion and more to get EHR, digitalize our health record, digitalize health systems. All right, what can go wrong? So on the left, what you're seeing is the graph of HITECH Act in 2009 and adoption of EHR. What you're seeing there is 96% and above adoption of certified EHR by 2015. I still remember my first day as an intern in a heme-onc ward at VCU Medical Center, and half of that rotation were on paper-based chart. I would see patients 3 times a day before I go home at 6 or 7 p.m. And we were said, no, we are going to document in the EHR. How many of you resonate with this story? We were said, we are going to do everything in the EHR. And we, including attendings, were sitting at 11 p.m., 12 a.m., just documenting, charting. And then we have to come tomorrow morning and see the patient. I think 5 or 6 attending quit during that transition. So that has been the impact of the EHR implementation and digital transformation in healthcare. What about the patient perspective? So this is a very famous picture, really lovely picture, crayon drawing of a 7-year-old girl, how she saw healthcare and how she perceived her encounter at a pediatrician clinic in 2011, and it was republished in 2020. What do you see here is not only beautiful picture. What you see here is the 7-year-old sitting on the patient's chair, and her sister sitting on the close by chair, and the mother with an infant on the other chair. What you see here is a physician who is typing away. Does it look like what we do today? Only one thing she got wrong. The doctor is smiling. I don't know how many, you're so right. I don't know how many of you would be smiling. So what about, and this is, the next one is, this is a publication we did when in my previous role at VCU, Virginia Commonwealth University. We compared, the question was, Epic is better or Cerner is better, what EHR is better, was the question we are trying to ask, and understand the experience of you, of us, into the EMR world. So this is graded between -100, this is based on a class survey, -100 to +100. So that's the range we're talking about. And the VCU at that time was on Cerner, which is on the left side, and then University of Chicago Medicine, it's a University of Chicago program on the right. We came together and say, hey, let's compare our physicians and nurses' experience. Let's see what comes out. Maybe Epic is better, maybe Cerner is better, maybe it's the physicians. Well, you can see this at VCU, 361 clinicians participated in this, 150 physicians, 84 nurses. On the University of Chicago side, 455 with 202 physicians and 93 nurses. Well, it's starking, right? EHR net experience score was negative for VCU physicians, and it was not too good for physicians at University of Chicago who was using Epic. So it was really poor. You're talking about not really a big difference. And look at this. This is what was promised, right? During the implementation in 2009 HITECH Act. It is going to improve analytics reporting efficiency and external integration. Look at that. At VCU, they said 7 out of 150 physicians said that it improved external integration. That was one of the biggest promises. And look at University of Chicago, 34 out of 202. So just shows you what EHR has done to us, or the digital transformation has done to us. Here is a great articles around the burnout. On the right, you're seeing 2013 to 2017 burnout. Every specialty, you can see the increase in burnout. It's an epidemic. In 2023, more than 50% physicians were burnt out and depressed. It really gives you an understanding of how we did what we did. And another promise was productivity, right? EHR is going to improve productivity significantly. Well, this is a 2-year-long research. What it talks about is it decreased access. There were fewer patients seen after 2 years still. So yes, it did not impact the money overall, but they were actually reduced access. So what did we go wrong? Where did we go wrong? And actually, it was pretty predictable. Research from banking, research from Wall Street, research of any digital transformation has shown this. It's a productivity paradox. And it was expected. It lags behind. There's issues around measurements and others. But the way I think about productivity and productivity loss and paradox is 2 things. There's an improvement in technology, which I think it has improved leaps and bounds from 2009 to 2025. Amazing changes. But the most important thing is what we did previously was take a paper-based processes and put it in the digital format. It did not work. We did not reimagine work. We did not think, how can we change it in a way which supports clinical care? And that's where I see the AI as an answer. So quickly, I don't want to bore you with technical terms and what's behind the maths here. So artificial intelligence, and that's what I think this can reimagine the work we do. It can help us what we want to do and what we don't want to do. So artificial intelligence is a spectrum. It is not one tool, one method, one technology. It's a spectrum, and we have been using it, and I'll show you the timelines around that. Basically, it's the machine ability to do tasks which requires human intelligence. So think about looking at the data pattern, understanding the data pattern, memory, problem solving, and decision making. Think about that. Too many things happens here. Let's go to the next layer to that, machine learning. And this basically is the ability of machine to learn the pattern and then predict. I'll give you a great example around supervised and unsupervised learning. Supervised learning, think of like, training AI tool. I don't know how many of you have Tesla, but when you are driving any Tesla, you would see, car popping up on the right side or the left side. Basically, what they have done is taken humongous amount of data and trained the machine to learn if this is a car, it is not a car. So take a picture of the car, tag it, yes, car, no car, this car, that car. That's supervised learning. And then machine gets better at that as we move forward. Unsupervised learning, think about, categorizing. Categorizing, patients with hypertension, patients with diabetes, patient with high risk of admission. So machine learns, you give some parameters and it learns and understands that which would be high risk for readmission, which patient will be not high risk for readmission. So that's unsupervised. So now let's go down a little bit at deep learning. You must have heard this term. Deep learning is when there are lots of neural network. And we're going to go a little bit in around the neural network and talk about this. And then under that is general AI. We'll talk a little bit more on that. I just wanted to really briefly show you what each of those Venn diagram does in terms of healthcare and where it can take us, right? So patient risk stratification, likelihood of readmissions, medical imaging segmentation we talked about, medical image synthesis, doc box, drug discovery, and prediction of diseases. We'll go a little bit deeper in those as we move forward. So AI is not new. AI is not new. You can see here in this graph, AI starts where, Alan Turing in 1950s gave birth to where a question was asked to a human and to a machine, and then compared by evaluator saying which did better. The real change was in 1957 when the neural network was Rosenberg developed that. And how we think about this in 1970s, expert systems. So all those order sets you guys use, right? You guys use summary views, right? All those are expert systems. Basically, it's an algorithm which is set, is like, okay, patients, if I'm giving this vancomycin, this is the creatinine, this is the GFR, calculate this based on the weight and age and others. So that is a fixed algorithm. It takes things and produces that. That's the expert system. Really hard to manage that. Tons of things goes on there because you have to change algorithm every time. And 1990s, the ML, which we just talked about, where can recognize. And then 2022 game changed with generative AI. Just a quick update there. So quickly, I just talked a little bit around neural network. I think it is important for us to think about this because this will help us understand the capabilities of AI. We talked about neural network here. I'm representing this at the layer as a human when we are trained to make decisions on pneumonia, let's say, right? You get data from the x-rays. You get information from the nurses which have put in the terms of vitals. All that becomes a node for you, information. And then the hidden layers, what the radiologist said, what the pulmonologist said, comes together. And as an attending physician, then you make okay, I weigh this information this way, I weigh this information this way. and this is a decision. So this is neural network. This is human how we think, and this is what is being actually behind the scene as the computers are thinking about this and what is represented up top. Deep neural network is multiple layers of those decision trees. So you saw that it was developed long time back. What changed in 2022? Why did the chat GPT just change the conversation? This is because of this transformer model. The transformer model is, as you can see here, there is input, that becomes another input, that becomes another input. This is a sequential model. It cannot it has to go in the sequence fashion, which is very slow, and it does not really work as well. But what happened in a transformer model, it could parallel process. It could have this attention. You see the mention of attention? It had attention to the whole thing all together. And that's your gaming GPU. That's what the gaming does. That's why NVIDIA got so much bigger. Intel did not do that because Intel was more sequential processing, and NVIDIA was parallel processing transformer model. Just a kind of framework to think about why this is happening. Well, one question I always get asked, because I think this helps us to understand how do model understand text. We had a conversation here, and Rayan was talking about this as well. So, computers were really good understanding maths, numbers. But how did they start understanding language? Well, break the language in numbers. That's what happened here, right? So here is a word embedding, which is semantic, similarities, and syntactic, the rule of the grammar, coming together in a vector space. That's how all the data in terms of generative AI is put together in a vector fashion. So look at here, man, woman, king, and queen. Top, you're seeing the parameters, right? Living being, human, gender, royalty. Give some numbers, right? So now the AI LLM model can understand man and woman in two different vector space on the left up top, right? And king and queen in a vector space, and they are related, right? So that's how machine is understanding your inputs in a vector fashion. And what is the Gen AI models, LLMs, doing? It's taking all the internet data, which is a huge amount of data, it's taking the text, the images, the speech, the video, structured data, putting it in the vector. I just showed you. Think about that, putting in the vector. That's called as a pre-training. Then it is being that tagging thing which you just talked about. It is tagged. It learns. And then fine-tuning is the process where we are going and making it specific to a domain. So fine-tuning is happening. And then these are the 5 things the Gen AI does the best. Question answers, sentiment analysis, information extraction, object recognition, and imaging caption. So when we are thinking about what are the bounds of generative AI, think about those tasks. All right, I'm going to go quick now. I just wanted to show you the impact of the parameters. I talked about the parameters up previously in the slide, right? That those are the parameters. There are billions of parameters. And this is what happens when the parameters increases. They start making sense because there are billions, and now there are trillions of parameters. On the left-hand side, what you're seeing is the right-hand side is the evolution. So the transformer model started 2018, and see how it changed what we talk about today. I'm not going to go into all GPT up there. There's a lot we can talk about, but let's really go to the crux of the conversation today. Application of AI in clinical medicine. I will skip this, but I will see if at the end, if there's time left, we'll go and do this. It is human versus physician. Who is better in X-ray recognition? we'll do that. Hopefully, we have time there, and we can see how they do it. But irrespective of that, this is computer vision. And we have learned EKGs. I'm sure all of you know what EKG and interpret EKG in different fashion. We can understand rate, rhythm, AFib, VFib, and all those good stuff. But here, what you can see here is computers can say beyond. The AI can say beyond what we see and what trained them. That's the computer vision. We do not know that, but computer can recognize it. In 2019, through EKG, you can predict age and sex. Through EKG, you can predict anemia and hemoglobin level. Through EKG, you can predict filling pressure. Through EKG, you can predict stroke risk, hyperthyroidism, peripartum cardiomyopathy, diabetes and prediabetes. So it goes beyond human capability once trained. What about endoscopy? And this is again, AI is unlocking new insights. We are talking about it can predict diabetes and blood pressure control, calcium score in the heart, Alzheimer's, Parkinson's, a heart attack, and stroke, even liver and gallbladder disease. It's just crazy, like how much we miss as a humans, and kidney disease. This is all latest research. You can see all new, as you see here. Well, let's go back to how it relates to us, as clinicians, as physicians. So this is a EMA slide. I was working there for four and a half years, and I was at the physician satisfaction and sustainability group as digital health. And through that, you might know this group as most of the research, Dr. Sinsky and others, burnout work comes from this group. And for us, right, we kind of did this national surveys and everything else. What is the negative pressures on physicians? Why do we feel burnt out? We saw that picture that in 2023, more than 50% of the physicians were burnt out. Because EMR not only increased burnout, but it was said that they increased burnout, but there are other things going on here, right? It increased, there was more, focus on how they worked. Are they filling the 20-minute slots? Are they coming at 8 a.m., right? Do they have, how much control they have of their work? Excessive documentation, right? Clinical information, finding clinical information, prior authorization, all burdensome quality reporting, all came together. And these are the things you're feeling and increasing the burnout. So let's examine this and how AI can help you. All right. Moving forward, this is the largest study I could find around physician time spent. So this was published, I think, in 2020. And it consists of 100 million patients encounter, 155,000 physicians, and 417 health systems. What it showed was each physician spent 16 minutes and more per encounter. Think about this 20 minutes encounter, and this is outpatient medicine. 20 minutes encounter to 30 minutes encounter, that's the general template time. 16 minutes per encounter, out of which 33% of the time was spent on the EHR chart review, 24% on documentation, and 17% on ordering. So think about this. Out of 20 minutes of encounter, 16 minutes on EHR, and these are the activities you're doing. Can AI help? And then we'll answer that question. So before I left the University of California into my new role, we implemented something called as ambient AI. And I was one of the first actual patients. So I was not as an administrator going there. This was a wonderful experience. And my primary care there is fantastic as well. I entered the room and we talked about everything on the earth. Hey, how was your vacation? Hey, what did you do today? What's the plan tomorrow? And all those things. I don't have a lot of medical history, so there was not much to talk about it. And then I left and he sent me a note. Hey, Vimal, I forgot about vitamin D level, which was low last time you were here. I'm like, okay, how did that happen? So AI technology, it was embedded in his mobile phone. It was listening to all the conversation. We had the conversation and boom, it just produced only specific thing which pertained to the clinical encounter, my clinical activities, and actually helped order vitamin D for me, which we forgot in that conversation. That's ambient AI. Okay, what does the research show? This is pretty new, right? What does the research show? Here is the Epic embedded AI. It just, you talk, it produces, it's pretty seamless. Really cool. And he said, I save so much time, I don't have to think about it. It helps me decrease cognitive load. It helps me not go home and write notes. I get done every day. I do this on time and with higher RVUs. So this is a new study from Stanford, I think, and basically saying that they're already seeing this ambient AI decreasing about 20% less time per notes, because you have to review it. Remember, AI is AI, you are liable. So 20% time per note, per appointment. And there are new studies which have come on actually impacting burnout score and decreasing it. So think about this, how much it can save for you as you implement this in your system. All right, we saw 33% time, right? Where was time spent in reviewing chart. And I think I was talking to you, right? About reviewing chart. Do they do a better job? Does AI do a better job? Let's look at the research. So this is a research published in Nature. What they did was they did 8 different models. There are different chatbot models, there are LLM models. 6 of them were open source, 2 of them were proprietary, GPT 3.5 and GPT 4 up tops in the model, as you can see. Methods, I just talked a little bit about that, is QLoRA, which is basically a fine-tuning methods, or in-context learning, which is more of a, give them an example, let the machine learn, and think about it next. So that is an in-context learning. And the task, radiology report, progress note, patient health questions, and patient-doctor dialogue. So in this method, they found that ChatGPT 4 performed the best in the model section. And then this was randomized between physicians and the machines. There were 115, I think 13 or 1,500 cases which were reviewed this way. And then at the end of it, the clinical reader study, there were 5 hospitalists and 5 radiologists kind of reviewed the answer it produced, summarization of the chart of those activities, the radiology reports and reports. And then it was analyzed for safety analysis as well. Here's the answer. I think we did talk about completeness. We talked about correctness. We talked about conciseness. On the top A box, what you're seeing is left, medical expert, which is in the red, and right on the best model. So it's blue, red, and blue kind of thing. In B box, what you're seeing is who performed better, the you see the blue are performed better for completeness. And completeness is defined by more completely captures important information. And you see an asterisk there, right? For radiology report, for patient questions, for progress notes, and for overall. That's statistically significant. In correctness, which includes less false information, you already see that machines, it's a little bit bluer than it should be. Patient questions, as well as for overall, it performed better. And conciseness contains less non-important information. Machine did better, ChatGPT. What was the really surprising thing, and this opens a Pandora's box, and I think there's more research to be done here, is on the right D box, or your left D box. What you're seeing there is they compared for the safety and saw that 21.7% medical expert missed something, and 15.5% for the machine as well. And then extent of likelihood of missing something also compared there, which really kind of comes to the point that it's not perfect. And humans are not perfect too, but they perform better. So this is one activity. And the last box, what you're seeing here is in the C, which is basically comparing the how much they were preferred. And you can see it is non-inferior. Machines' answers were non-inferior. And on the last box, we are just seeing how it was scored, right? So the question, what was the input? What was the summary by A and B, and how they kind of summarized it. So machine do better summarization. Machine can, help you do what you want to do, talk to the patient, and can summarize you better. So here's a 50% time already saved. What about, can machine do better in clinical reasoning? Can do. Any hands? Yeah? Yeah? No? I think most of the people say no. Well, here is some report. ChatGPT outperforms doctors in diagnostic accuracy. Tons of news. And again, this is a small study. We have seen this report, right? This is a Stanford students. About 14 clinical cases were compared from 2019 to 2022 for clinical reasoning final exam for year 1 and year 2. Compared it with the GPT 3.5 and GPT 4 and medical students. 70% is the passing score. Here's the result. I give big kudos to the students. They did pretty well. But ChatGPT did well too. And ChatGPT 4 did better than ChatGPT 3. But again, remember, this is 14 clinical cases. So, right, you would say to me, okay, they are learning from the questions we have put in the internet. And they're answering the question. Does it really help me? Is that a clinical reasoning? And here is how they train the models, right? You say PubMed, question and medication question and answer, USMLE question and answer, they put it together. And then you see in 2020, they failed. So 70% is the passing mark. They failed again, they failed again. And then reached in 2022, 50%. And then boom, it went to 67.6%. And MedPalm 2, 86.5% times correct answers. So does that mean that they make a better clinical judgment? Actually, there is a little bit recent study here in terms of the clinical reasoning and diagnostic reasoning randomized control trial. What was done here was 50 doctors, 26 attendings, and 24 residents from family medicine, emergency medicine. They were randomized between physicians for ChatGPT 4. Anyone have used ChatGPT 4 here? Perfect. So they randomize it. Okay, human plus doctor better, right? Right. Said, okay, do that, and do that with the conventional resources, physicians, like use PubMed or use, UpToDate, as we do, and see what comes out. They chose 110 cases, but out of 110 cases, they chose just 6. They gave them 1 hour to complete the exam and complete the assessment. And then 2 blinded board certified physicians evaluated the response. So mind it, this is a blinded study. This is a real patient which never been exposed to internet. So what we are trying to refute here is clinical reasoning. The question we are asking is, all right, you gave me the answer which I had already given you in the internet. No, but now I'm going to ask you the real world questions. It is really complex and it is really diagnostically challenging. Can you come up with the answer? Here's the result of physician plus conventional resources. More than 70%. It's pretty good, right? It's pretty good. What would you say? How did ChatGPT plus physicians group performed here? Higher? Higher? Not significantly higher. It's not statistically significant. Well, why did you see so many reports that ChatGPT defeated physicians in clinical reasoning? Here's the answer. ChatGPT by itself did so much better. That was statistically significant. So does that mean we are going to be replaced? This is a question I get all the answer like, oh my God, okay, computers are doing this. They are better in understanding information. They are better in summarizing. They are better in clinical decision making. Then what? What about human touch? Who will take care of the patient when I'm talking to them eye to eye? I'm touching them, right? I am asking them the questions, the physician-patient relationship. How do we do that? Well, here's the answer for you, or at least a research for you. So Google better performs, and this is, of course, centralization of the results. Here, what they did was they took 149 cases, the PACS, patient actor, and case scenarios, and they sent it in a synchronous text chat fashion and randomized between AI and the primary care physician. And these primary care physicians were in US, Canada, and India, 20 of them. And based on the question answer, they were evaluated by specialist physician, as you can see, and then by the patients for their diagnostic accuracy and quality, diagnosis and management, patient-centered communication best practices, and practical assessment of clinical examination skills. How did they perform? Well, let's take a look. So on here, what you're seeing is the chart where patient actor perspective and on the right, and the specialist physician perspective on the left. What it shows you, the blue or the purple is the PCP, and the pink is the AI model. For physician specialist perspective, escalation recommendation actually were about similar, but diagnostic accuracy and management plan better for AI. And from the patient perspective, empathy was so much more better than the primary care physician, because they are like, oh my God, I'll give you how it is. But they are answering like, oh, I understand what's going on with you, taking the time and answering the question. So what we are trying to understand is like, okay, they can do things faster, more efficient, more effectively, can better diagnose, have better empathy. Is game over? Well, given the time, I'm going to skip this part of it, but I'll give you some resources to think about how you can utilize AI for yourself. How can you make it your own assistant, research assistant, right? Here is a concept called as retrieval augmented generation, which is where AI cannot know those proprietary information, things you're thinking, how you are thinking, but you can actually create your own toolbox to help you the way you want to do it. So this is a RAG model, which this is a MedAdvisor which I created, and it is based on specific proprietary data, 19 years of training put together in a document which has been saved in a HIPAA compliant way. And I tested this for 5 different clinical use cases, and I compared it with the app out of the box ChatGPT and the differences, and it performed much better. And because it is based on the real world information and proprietary information from the medical knowledge. And it gives you the grades. Some of you tried it. It gives you the grade. It gives you the evidence base. It gives you the kind of information you look for as a physician. So everybody who has camera, please go in here. We are going to create this together. All right. So we have had so much flurry of information, data, research coming out. It's really hard to keep track. Wouldn't it be great if we had this lecture, what I'm giving right now, could have been done easily, and maybe you can do it when you are, you can review it when you are driving as well. So I'm going to show you. These are some of the research, things. I have hundreds of them, which is put together. And the same thing you can create for yourself. I basically said, okay, create me a summary of all the research I have uploaded. AI in medicine. It went through all my left-sided resources and created me a great summary there. What if I did not have time to read all that? What if I wanted to kind of listen when I'm kind of driving to work? You can do that with that app, which I just talked about. It actually condenses it, understands it, what you're asking for, ask question, create questions and answer, clarify questions, and everything else. That's the power of AI in your hands right now. And how we use it as physician is dependent on us. And there has been a lot of questions, and I think that one question was also asked around, hey, I get false information. And Open Evidence is a great tool. This is a recent launch, Open Evidence, basically making sure it's grounded in reality and each of the evidence is verified. So if you don't have that, you should have that on your computers or on your phones as well. You see there, it's written prior authorization. You can do prior authorization using that. See how it works for you, how AI is going to help us. So let's move on to intelligent operations. We talked about generative AI operations intelligence. So this is the research we did at VCU where we had issues around, cohorting our patients in the wards. The patients were spread 19 different units, different towers. It was really a nightmare. We saw that we just spent 9 minutes for 20 minutes of walking. So 20 minutes patient encounter from one place to another, only 9 minutes with the patient, which was not really good value added proposition. We did try to answer this question, try to help and try to implement changes. And every time we did anything, it actually increased length of stay in the ED, it increased length of stay for the patient. And it really, really did not work. 3 times it failed before we started analyzing and thinking about how can we do this differently? How can you use computers and real data in changing that? So what we did was we took large data from the EMR, put it into the systems, simulation system. We had time motion study. We kind of tagged, we got some students, medical students, and health administration student to tag along with the physicians and time what they are doing, what activities they are doing, have the patient arrival census, discharge census, hospital layout, current team assignment. And then we created something called as a value stream mapping and then put this into a model and asked it to run it. We compared that data information, what came out of it is like how the system will perform to the real world system. And we found the R square was 0.99, which is fantastic. Like it's representing the real world clinical operational data. Here is what came out of it visually, but there's a lot going on behind the scene. You see the patients coming in. I have flattened it. It's not those towers which you can see. Patients are coming in. You will see some attendings and residents kind of running around like chickens in the morning, 8 a.m. with a coffee mug in their hand, seeing patients in a few seconds. There you go. It gives you the visual, what we do every day in the morning when we are seeing patients. Well, it looks visually pretty appealing. It makes sense. And then we ask these questions because we know that our systems performed at the level that relate to the real world. We ask questions. Okay, if we we assigned patients in a particular unit differently, how would it change the outcomes? If we added, increase the number of admissions, decrease the number of admissions, number of patients, number of nurses, number of units, all those questions were being asked. And it spit out the answer based on these metrics. What will happen to the system, what will happen to the team, what will happen to the nursing, what will happen to the rounding metrics, and all those stuff. And then at the end, it spit out this answer that the best way for the cost, operations, and everything else is future state, which is add a team and increase the admission. Well, did it work? 3 years later, number of patients were cohorted more than 90% of the time, the right units. Length of stay decreased, length of stay for emergency department decreased, and discharge before noon increased. Again, something for us to think about how complex adaptive the systems are. I'm gonna just quickly end with this. Is it end for us, right? We are at the hype phase right now, the peak of expectation, and there's a lot we need to learn. We have a lot to do. I'll just give you this example. This was MD Anderson and IBM Watson. Do you remember that? It closed after 62 million investment and unsafe treatment condition. So we should never forget this. This is very early stage for AI. Here is some of the things which you would probably, this is the publication in 2023 that I think you referred to, where the question asked, the machine hallucinated the answer if they did not find the answer. So we should be extremely careful about verifying what information they are spitting out. Here, what you see in GPT 3.5 and GPT-4, the questions asked on the right side for for glaucoma, for cornea and other information, GPT-4 actually hallucinated more than GPT 3.5. So I don't think we are ready yet to let machine handle everything. Here is, I showed you a deep fake when I started this conversation. That was used for a financier in Hong Kong to pay out $25 million. And it happened. This was a real example. There's a lot of bias, error, and ethic issues. I helped through IPPS, AMA, to kind of come up with some of the guidelines on augmented intelligence development, deployment, and use in healthcare. If you're interested, you should look at it. It talks about the liability as well for physicians. United Healthcare, faulty AI. It's going to be war of AI versus AI. Whose AI is better as we move forward? And then, there's also misdiagnosis and bias around, patients with color. Again, I think you all are very aware of what happened to Tesla and the deaths associated with Tesla autonomous driving. It is, again, I can go in the deeper conversation around this, because AI is based on some of the learnings, they cannot understand human, can understand that that's something fallen and you should not pass along, but AI does not have that information and just crashes. So there's a lot to do. Next phase of AI, I would say, is about how do we really, it's an implementation failure as we started with the digital transformation conversation. It's the implementation failure. How do we enhance rather than replace? And I see next phase of how do we do large scale integration of AI to improve not only clinical efficiency and effectiveness, but also enhance physicians. And this is the program I launched, Connected Care Center at UC Davis. And you will be seeing, I don't think I have time to talk about more about this, but this is going to get published as a pre-publication, which will be coming in May. So what you're seeing here is how AI-enabled, digitally enabled care model actually decreased your ER diversion and many things coming together. Also improve the quality for the patients, quality for the physicians and others. So a lot more research. How do we do this, integrate thoughtfully into the health systems and into the clinical care is the next phase of AI as I see it. So I want to stop there. And I know we might not have too much time on the question, but thank you.
Questions for Dr. Mishra? All right, so maybe I'll start. So what your thoughts are on Bill Gates' statement that in 10 years there won't be any physician?
I think I'm with you all. Let's put it that way. I don't know it's going to replace, but I really like the answer you gave, right? What is high yield, what can be replaced, and what cannot be. And it depends on where in the spectrum. Are they going to create new science? I'm not sure yet. Humans will be needed to create new science and more complex, deal with more complex issues, as we saw in the car example.
Other questions? I see we are running out of time, but go ahead. Please,
Thank you, Dr. Mishra. I think it was a great talk. So one of the things with any change that happens at an operational level and even with artificial intelligence would be, how do you measure the outcomes after you implement it? So at your institution, the AI initiatives you're taking, my question is, one, what are the barriers you see in implementing those initiatives most of the times? And second, how do you measure the improvement and ensure that improvement is, going forward?
Yeah, I think that's a great question, and I see majority of the you might have seen the research around it takes 17 years from bedside to translation of any kind of research into it. It's all about implementation and how we implement it, how we measure it. And I think many times we implement without measuring, and clear example of the digital transformation. We did not measure, we did not anticipate. And how do we do this value stream mapping, understanding how it is good for our physicians, how it's good for our clinicians, how it's good for our patients, how it's good for our health systems, and how it is good for our patients' experience and family member experience, and what really looks good, and evaluating and implementing it to measure those things is going to be my recommendation as we implement things, to make sure that we are not just trying to optimize money, and we're not trying to only optimize physicians, or we are trying to only optimize some certain part of this. This is a balanced scorecard. That's what I would say.
There's a virtual questions from our virtual audience. Questions from virtual audience. For those of us who will only be using this technology rather than developing or researching, what skills should we focus on for adapting to the coming changes?
That's a really good question. And I ponder about this every day. I talk to my students and we kind of talk about this. I think physicians in this classroom and beyond should be the masters of how we use it and how we use it safely, effectively to support next healthcare. Because as we saw, that when the decisions are not being made and led by clinicians who understand clinical care, it can, boomerang. So I would say the major thing is to learn what the capabilities are, to experiment with it, see what works, and really get together to understand how it can help you. And what resource I shared today with you, the Notebook LM, I think would be a good start. Start asking questions. Start asking questions to see what kind of answer you get. Is it the right answer? And I would say prompting, because when I graduated my med school, my dean said to me, "You're a doctor. You got to practice you got a license to practice. You got license to kill. You got license to heal. What you're going to choose. It is not about how much you know, but how you ask questions." So I think the critical part of this conversation is, as a physician, we need to know how to ask right questions to the LLMs so that you get the right answers.
Thank you. I see we are over time, 108. Notebook LM actually has a free version. It's a Google product. I don't own any stocks in Google. As a disclaimer, so the free version, and then there's a paid version also. So Notebook LM that you were talking about. So that's those of you who have Google accounts, Gmail accounts, can use that, and they come up with some new widgets also for the AI Gemini platform that are, I think, quite interesting also. Thank you, Dr. Mishra, and thank you.